presents Evaluation and Management by Christy Zielinski and Anne-Marie Gould. Learning Objectives. By the end of this webinar, participants will be able to apply current E&M coding guidelines, 2021 to 2026 updates, distinguish medical decision-making versus time-based coding, identify documentation gaps impacting risk adjustment and reimbursement, avoid common audit triggers and denials, integrate E&M into CDI workflows and physician education. Disclaimer: this webinar is intended for educational purposes only to support clinical documentation integrity professionals, coding staff, and healthcare providers in understanding compliant documentation and query practices. The sample queries, documentation tips, and clinical indicators provided herein are illustrative examples based on the AHIMA, ACDIS guidelines for achieving a compliant query practice, 2022 update, current through 2025, and widely accepted CDI principles. They are not official regulatory guidance and do not replace facility policy, coding guidelines, payer instructions, or provider clinical judgment. Users must apply organizational compliance standards and current coding conventions, ICD-10 CM/PCS, CPT, CMS, and official guidelines for coding and reporting when developing or issuing queries. All patient scenarios are fictional and for demonstration only. Any resemblance to actual persons or cases is purely coincidental. The author and publisher assume no responsibility or liability for decisions or actions taken as a result of using this material. Readers are encouraged to verify current regulations and consult compliance or check with facilities' policies and procedures. Key documentation mindset shift. Old way. Document more to get higher level. New way. Document your thinking to justify the level. What is E&M? Evaluation and management services represent the intellectual and clinical work performed by healthcare providers during a patient encounter. E&M includes 1. Patient evaluation. Gathering history, when relevant, assessing signs, symptoms, and clinical status. Identifying acute versus chronic conditions. 2. Clinical judgment and decision-making. Determining diagnoses or differential diagnoses. Evaluating severity and risk. Deciding level of care, outpatient versus inpatient versus ICU. 3. Data analysis. Reviewing labs, imaging, and diagnostic tests. Interpreting results, not just reviewing. Comparing prior records and trends. 4. Care management. Ordering medications, treatments, or procedures. Coordinating care with specialists or teams. Monitoring response to treatment. 5. Risk assessment. Evaluating risk of complications, morbidity, or mortality. Determining need for escalation of care. Documenting high-risk situations appropriately. Simple way to explain E&M. How you think, what you decide, and how you manage the patient. Why E&M matters. 1. Drives billing and reimbursement. 2. Reflects severity of illness. 3. Impacts quality metrics and risk adjustment. 4. Supports audit defense and compliance. CDI perspective. E&M is not about how much you write, it's about how clearly you show complexity, risk, and medical necessity. E&M tells the story of how sick the patient is and how complex your thinking is. Key governing body. American Medical Association, Centers for Medicare and Medicaid Services. The major shift, 2021 still in effect 2026. The biggest transformation in E&M coding. Focus moved away from history. Physical exam. Focus move to medical decision making or total time. What this really means. Before 2021, coding was based on bullet counting. Providers documented long notes to meet requirements. Now, 2026. Coding is based on clinical thinking and complexity. Documentation must reflect decision-making, not volume. Less note bloat. More meaningful documentation. Key takeaways, 2026. Office and hospital codes are most used. MDM drives almost everything. Time is secondary option. Consultation is rarely used. Office/outpatient visits. 99202 to 99215. Office and outpatient evaluation and management services are the most commonly billed physician encounters and are used for clinic visits, primary care visits, specialist office visits, outpatient follow-up appointments. These codes are selected based on medical decision-making, which is primary method, and total time on date of encounter. New patient office visits. 99202 to 99205. A patient is considered new if the patient has not received professional services within the past 3 years from the same physician or another physician of the same specialty/subspecialty in the same group. New patient code levels. Code 99202. MDM level straightforward. Typical patient minor/self-limited. Code 99203. MDM level low. Typical patient stable chronic illness. Code 99204. MDM level moderate. Typical patient acute illness/exacerbation. Code 99205. MDM level high. Typical patient severe/high-risk condition. Here are the details for the following new patient office visits. 99202, straightforward. Typical features. Minor complaint. Minimal risk. Limited data. Example. Mild seasonal allergies without complications. OTC treatment recommended. Documentation usually includes simple history, minimal assessment, OTC management. 99203, low level. Typical features. Stable chronic illness. Limited data review. Low risk management. Example. Controlled hypertension evaluated with medication refill and routine lab review. Supports. Stable chronic conditions. Basic labs reviewed. Minimal medication adjustments. 99204, moderate level, most common for specialists. Typical features. New undiagnosed problem. Acute illness with systemic symptoms. Chronic illness with exacerbation. Example. New patient evaluated for worsening COPD with dyspnea requiring imaging review, steroid management, and treatment planning. Often includes multiple diagnoses. Prescription drug management. Imaging/lab interpretation. Moderate risk decisions. 99205, high level. Typical features. Severe illness. Threat to life or bodily function. Extensive data review. High risk management. Example. Patient with suspected sepsis and acute respiratory failure requiring immediate workup, coordination with hospital team, and urgent escalation of care. Supports: organ dysfunction, high-risk decisions, extensive review/interpretation, potential hospitalization, established patient office visits. Codes 99212 to 99215. An established patient is one that has received professional services within the past 3 years from same specialty/group. Established patient code levels. Code 99212. MDM level, straightforward. Typical patient, minor issue. Code 99213. MDM level, low. Typical patient, stable chronic illness. Code 99214. MDM level, moderate. Typical patient exacerbation/new issue. Code 99215. MDM level, high. Typical patient severe/high-risk illness. Below is the explanation of each codes. 99212, straightforward. Typical features. Simple issue. Minimal treatment. Minimal risk. Example: follow-up for resolved rash, no medication changes needed. 99213, low level. Most common primary care code. Typical features. Stable chronic condition. Low-risk management. Example: diabetes follow-up, stable blood sugars, medication continued. Usually includes 1 stable chronic illness. Basic lab review. Minimal changes in treatment. 99214, moderate level, very common. Typical features. Exacerbation of chronic illness. New acute illness. Prescription medication management. Example: CHF exacerbation with edema and dyspnea requiring diuretic adjustment and close monitoring. Common drivers. Acute exacerbation. Prescription drug management. Moderate risk. Multiple conditions managed. Important 2026 audit focus. Documentation is copied forward. Risk is not explained. Complexity unsupported. 99215, high level. Typical features. Severe exacerbation. Threat to life or function. High-risk treatment decisions. Example: patient with severe uncontrolled diabetes and acute kidney injury requiring urgent medication changes and coordination of hospital admission. Supports: organ dysfunction. Significant risk. Extensive management decisions. Time-based office visits. Office/outpatient codes may also be selected using total time on date of encounter. What counts toward time? Reviewing records. Face-to-face evaluation. Counseling. Ordering tests/medications. Documentation. Coordination of care. Time must include total minutes. Activities performed. Valid example. Total time 42 minutes including chart review, evaluation, counseling, medication management, and documentation. Key MDM drivers in office visits. Problems. Acute versus chronic. Stable versus worsening. Severity. Data. Labs/imaging reviewed. Independent interpretation. External records. Risk. Prescription management. Escalation of care. Risk of deterioration. Common Office E&M Audit Risks, 2026. Cloned Notes. Unsupported 99215. Labs reviewed without findings. No risk explanation. Diagnosis listed but not managed. CDI opportunities in outpatient evaluation and management. Clarify. Acuity. Severity. Chronic complications. Risk factors. Medication complexity. Weak versus strong documentation. Weak SOB. Strong acute hypoxic respiratory failure. Weak CHF. Strong acute on chronic systolic CHF exacerbation. Weak kidney issue. Strong acute kidney injury due to dehydration. Quick office evaluation and management summary. Code 9920299212. Typical complexity, straightforward. Common scenario, minor issue. Code 9920399213. Typical complexity, low. Common scenario, stable chronic. Code 9920499214. Typical complexity, moderate. Common scenario, exacerbation. Code 9920599215. Typical complexity, high. Common scenario, severe/high risk. Now let's discuss initial hospital care. Codes 99221 to 99223, Expanded Guide, 2026. Initial hospital inpatient or observation care represent the first encounter by the admitting physician or qualified healthcare professional. The provider's initial evaluation, assessment, and management plan for a hospitalized patient. Important 2026 rule. Since 2023, inpatient and observation services are merged into one hospital E&M category. This remains current in 2026. How initial hospital codes are selected. Primary method, medical decision-making or time, which is less common. Code 99221. MDM level, straightforward/low. Typical patient, mild illness, stable. Code 99222. MDM level, moderate. Typical patient, acute illness requiring evaluation. Code 99223. MDM level, high. Typical patient, acute illness requiring evaluation. Severe or life-threatening illness. Explanation of the initial hospital codes as follows. 99221, initial hospital care, low complexity. Typical clinical situations. Mild dehydration. Controlled chronic illness. Stable observation patient. Minimal diagnostic complexity. MDM characteristics. Problems. Stable condition. Minor acute illness. Data. Limited review. Risk. Low risk of complications. Example documentation. Patient admitted for mild cellulitis requiring IV antibiotics. No systemic symptoms. Labs reviewed and stable. Continue treatment and monitor response. What usually supports 99221? 1. Uncomplicated problem. Limited data review. Low-risk treatment plan. Stable patient condition. Common audit problem. Billing 99221 when documentation supports outpatient management only. Admission must still be medically necessary. 99222 Initial hospital care, moderate complexity. Typical clinical situations. Acute exacerbation of chronic disease. New illness requiring workup. Moderate clinical risk. MDM characteristics. Problems. Acute illness with systemic symptoms. Exacerbation of chronic illness. Data. Multiple labs/imaging reviewed. Risk. Moderate risk management. Example documentation. Patient admitted with acute COPD exacerbation and hypoxia requiring oxygen therapy, IV steroids, and frequent respiratory reassessment. Chest imaging and labs reviewed. Common drivers for 99222. Prescription drug management. Active diagnostic evaluation. Moderate severity illness. Ongoing monitoring needs. CDI focus. Clarify. Acute versus chronic. Exacerbation status. Hypoxia or respiratory failure. Severity indicators. Audit risks. Generic documentation like continue treatment. Without explaining why admission is needed. Why condition is moderate complexity. 99223 High level, most important. Typical clinical situations. Sepsis. Acute respiratory failure. Stroke. Acute MI. Shock. Organ dysfunction. This is the highest initial hospital level. 99223 represents severe illness with high risk of deterioration, organ failure, intensive monitoring, complex decision-making, MDM characteristics, problems, life-threatening illness, severe exacerbation, organ dysfunction. Data. Extensive review and interpretation. Multiple diagnostic studies. Risk. High risk of morbidity/mortality. Example documentation. Patient admitted with sepsis secondary to pneumonia complicated by acute hypoxic respiratory failure. Requires IV broad-spectrum antibiotics, oxygen support, and continuous monitoring due to high risk for rapid deterioration. What strongly supports 99223? Clinical indicators. Hemodynamic instability. Organ dysfunction. Severe hypoxia. Altered mental status. ICU level concern. Management complexity. Multiple interventions. Escalation of care. Frequent reassessment. High-risk medication management. Data complexity. Imaging interpretation. Extensive lab review. Consultant discussions. External record review. Most common 99223 audit failures, 2026. 1. Weak risk documentation. Patient stable. While billing high-level code. 2. Diagnoses listed without severity. Pneumonia. Instead of. Severe multilobar pneumonia causing acute hypoxic respiratory failure. 3. No explanation of medical necessity. High-level code requires. Why patient needs admission. Why condition is high risk. Why close monitoring is necessary. Medical necessity is critical. Even if MDM appears high, the admission must still be medically necessary. Auditors look for why outpatient treatment failed, why hospitalization was required, why close monitoring was necessary, using time instead of MDM. Initial hospital codes may also be selected using total physician/qualified healthcare professional time on the encounter date. Code 99221. Total time 40 minutes. Code 99222. Total time 55 minutes. Code 99223. Total time 75 minutes. Times may vary slightly by payer/reference source. Time documentation example. Invalid. Spent 40 minutes with patient. This is too vague and is audit risk. Valid. Total time 42 minutes including chart review, patient evaluation, coordination with pulmonology, and documentation. Total time 78 minutes including patient evaluation, review of outside records, coordination with ICU team, discussion with family, and documentation. CDI opportunities for initial hospital care. Focus queries on acuity, organ dysfunction, respiratory failure, sepsis clarification, risk of deterioration, severity indicators. Now I will discuss subsequent hospital care. 99231 to 99233, Expanded Guide, 2026. Subsequent hospital care codes are used for daily inpatient or observation follow-up visits after the initial admission encounter. These codes represent ongoing physician management, daily reassessment, monitoring patient progress, adjusting treatment plans, evaluating response to therapy. What counts as subsequent hospital care? These are daily progress notes, follow-up inpatient encounters, ongoing hospital management, how subsequent hospital levels are selected, primary method, medical decision-making or time which is less common. Code 99231. Complexity low. Typical patient status stable/improving. Code 99232. Complexity moderate. Typical patient status active illness requiring management. Code 99233. Complexity high. Typical patient status unstable/high-risk condition. Now let's go over each codes. 99231, low complexity subsequent care. Typical clinical situations. Improving patient. Stable chronic condition. Minimal treatment adjustments. Low risk for complications. MDM characteristics. Problems. Stable illness. Improving acute condition. Data. Minimal/limited review. Risk. Low risk management. Example documentation. Patient with CHF improving on current diuretic regimen. No respiratory distress. Labs reviewed and stable. Continue current treatment plan. What usually supports 99231? Stable condition. Minimal decision-making. Limited management changes. Low risk of deterioration. Common audit issues. Repetitive copied notes. Minimal documentation with unsupported code. No evidence of physician management. 99232 Moderate complexity subsequent care. Typical clinical situations. Acute illness still requiring treatment. Moderate risk. Active medication management. Ongoing diagnostic evaluation. MDM characteristics. Problems. Acute illness with systemic symptoms. Chronic illness with exacerbation. Data. Multiple labs/imaging reviewed. Risk. Moderate management risk. Example documentation. COPD exacerbation with persistent wheezing and hypoxia requiring adjustment of bronchodilator therapy and IV steroids. Chest imaging and repeat labs reviewed. Common drivers supporting 99232. Prescription drug management. Ongoing oxygen requirement. Moderate illness severity. Repeat diagnostics. Continued monitoring. CDI opportunities. Clarify. Acute versus chronic. Severity of exacerbation. Presence of hypoxia or organ dysfunction. Treatment intensity. Common audit failures. Continue current care without explanation. Lack of reassessment. No active management documented. 99233 High complexity subsequent care. This is the highest daily hospital level, reflects ongoing management of severe or life-threatening illness. Typical clinical situations. Unstable patient. Organ dysfunction. Significant risk of deterioration. Escalation of care. MDM characteristics. Problems. Severe exacerbation. Organ failure. Life-threatening illness. Data. Extensive review and interpretation. Risk. High risk of morbidity or mortality. Example documentation. Patient with septic shock and acute kidney injury remains hypotensive despite fluid resuscitation. Vasopressor therapy adjusted. Continuous reassessment required due to high risk for cardiovascular collapse. What strongly supports 99233? 1. Clinical instability, which includes respiratory failure, hemodynamic instability, severe infection, acute organ dysfunction, altered mental status. 2. Management complexity, which includes escalation of therapy, frequent reassessment, high-risk medications, coordination with specialists, ICU-level concerns. 3. Data complexity, which includes multiple diagnostics reviewed, imaging interpretation, consultant discussions, trend analysis of labs/vitals. Most common 99233 audit failures, 2026. 1. Patient appears stable, but code build is high level. 2. Lack of risk documentation, no explanation of why patient is unstable or why intensive management is needed. 3. Copy/paste notes, repeated documentation without clinical change, reassessment, new decisions. Daily progress notes should show clinical response, improvement or worsening, treatment adjustments, ongoing monitoring, physician reassessment. Examples of documentation: weak, patient stable, continue treatment, only minimal complexity supported, strong, Patient continues to require high-flow oxygen for acute hypoxic respiratory failure. Repeat ABG reviewed showing persistent hypoxemia. High risk for deterioration remains due to severe pneumonia. Using time instead of MDM. Subsequent care codes may also be selected using total physician/qualified healthcare professional time. Approximate time ranges. Code 99231. Total time 25 minutes. Code 99232. Total time 35 minutes. Code 99233. Total time 50 minutes. Time documentation example. Total time 52 minutes including patient reassessment, review of imaging and labs, coordination with nephrology, medication adjustment, and documentation. CDI strategies for subsequent care. Focus on severity progression, organ dysfunction, escalation/de-escalation, risk of deterioration, active management complexity, quick comparison table. Code 99231. Complexity low. Typical patient stable/improving. Code 99232. Complexity moderate. Typical patient active illness. Code 99233. Complexity high. Typical patient unstable/high risk. Note: subsequent hospital care should explain what changed today, why the patient still requires hospitalization, and what decisions were made. Now let's discuss hospital discharge services. 99238 to 99239, Expanded Guide, 2026. Hospital discharge management codes are used for the physician or qualified healthcare professionals' work related to transitioning a patient out of the hospital. These codes are based on time only, not MDM. These services include final patient evaluation, discharge planning, medication reconciliation, coordination of post-discharge care, communication with family/caregivers, completion of discharge documentation, hospital discharge codes. Code 99238. Time requirement 30 minutes or less. Complexity standard discharge. Code 99239. Time requirement more than 30 minutes. Complexity complex discharge. What counts toward discharge time? The provider may count total time spent on final patient examination, discussing hospital stay and diagnosis, discharge instructions, medication reconciliation, arranging follow-up appointments, coordinating home health/SNF/hospice, communication with nursing, case management, consultants, or family, completing discharge paperwork and records. Key documentation requirement. MD must document total discharge time, activities performed. Let me discuss the different codes for hospital discharge. 99238, discharge less than or equal to 30 minutes. Typical situations. Routine discharge. Straightforward transition. Minimal coordination required. Documentation examples: weak versus strong. Weak. 1. Patient discharged home. Medications reviewed. No total time documented. No discharge activities described. No evidence of physician work. Minimal medical necessity support. Too vague. Another example. 2. Total discharge time 25 minutes. Time alone is not enough. No explanation of what was done. Poor audit defense. Third example. Patient stable for discharge. Follow-up arranged. No medication reconciliation documented. No patient counseling documented. No transition planning details. Strong documentation. 1. Total discharge time 22 minutes including final patient evaluation, medication reconciliation, discharge instructions, follow-up planning, and completion of discharge documentation. Exact total time documented. Activities clearly listed. Appropriate routine discharge complexity. 2. Total discharge time 28 minutes including final assessment of improving cellulitis, medication reconciliation, patient counseling regarding oral antibiotic compliance, review of return precautions, coordination of PCP follow-up, and discharge documentation. Clinical status documented. Patient education included. Follow-up coordination included. Clear physician involvement. What makes a strong 99238 note? Required elements are 1. Exact time 22 minutes 28 minutes 30 minutes 2. Activities performed include final examination, medication reconciliation, counseling, follow-up planning, documentation completion. 3. Transition planning. It should show coordination of care, education provided, discharge readiness. Common audit failures for 99238. 1. Missing time. No exact minutes documented. 2. No activities listed. Auditors need to see physician work. 3. Copy/paste discharge notes. Minimal individualized planning. 4. Unsupported complexity. Routine discharge build with vague documentation. CDI opportunities. Encourage providers to document. Final diagnoses clearly. Clinical improvement. Ongoing risks after discharge. Medication changes. Patient understanding/compliance discussions. Quick comparison. Weak documentation. Discharged home. Strong documentation. Lists time plus activities. Weak documentation. No time documented. Strong documentation. Exact minutes documented. Weak documentation. No coordination described. Strong documentation. Follow-up and counseling included. Weak documentation. Generic note. Strong documentation. Patient-specific transition plan. Note. For 99238, the physician must document both the time spent and the work performed to safely transition the patient out of the hospital. On this slide I will discuss MDM level summary and MDM versus time. Level, straightforward. Problems, 1 minor. Data minimal. Risk minimal. Typical scenario simple complaint. Level, low. Problem stable chronic. Data limited. Risk low. Typical scenario HTN, controlled DM. Level, moderate. Problems acute illness or multiple chronic. Data moderate. Risk moderate. Typical scenario: COPD exacerbation. Level: high. Problems: life-threatening. Data: extensive. Risk: high. Typical scenario: sepsis, respiratory failure. MDM versus time, when to use each. Scenario: complex decision-making. Best method: MDM. Scenario: long counseling visit. Best method: time. Scenario: routine visit. Best method: MDM. Scenario: documentation unclear for MDM. Best method: time, if valid. Now let me discuss about emergency department visits, Expanded Guide, 2026. ED/E&M codes, 99281 to 99285. Emergency department evaluation and management codes are used for physician or qualified healthcare professional services provided in the emergency department. These codes represent patient evaluation, medical decision-making, diagnostic interpretation, stabilization and treatment planning. Important ED rules, 2026. ED codes are selected by medical decision-making, MDM, only. Not history/exam, not time, except separate critical care codes. Another important ED rule: unlike office visits, ED codes do not distinguish between new patients or established patients. All ED patients use 99281 to 99285. ED medical necessity matters. Even if MDM appears high, documentation must support why emergent evaluation was necessary and why urgent treatment/intervention was required. ED codes are based only on MDM. Risk and severity drive higher levels. Documentation must support urgency. Independent interpretation strengthens MDM. On this slide is the ED code overview. Code 99281. MDM level: minimal. Typical severity: minor problem. Code 99282. MDM level: low. Typical severity: simple acute illness. Code 99283. MDM level: moderate. Typical severity: exacerbation requiring treatment. Code 99284. MDM level: moderate high. Typical severity: urgent/high risk illness. Code 99285. MDM level: high. Typical severity: severe/life-threatening. Now we will discuss in details the different ED codes. 99281 ED visit: straightforward. Typical clinical situations: minor complaint, self-limited problem, minimal intervention. MDM characteristics: problems, minor issue. Data: minimal/no testing. Risk: minimal risk. This code usually includes minimal evaluation, minimal treatment, low resource use. Example documentation: patient evaluated for superficial abrasion after fall. Wound cleaned and bandaged. No imaging required. Discharged home with routine instructions. 99282 ED visit: low complexity. Typical clinical situations: minor acute illness, stable symptoms, low risk management. MDM characteristics: problems, Acute uncomplicated illness. Data. Limited review/testing. Risk. Low risk. Example documentation. Patient presents with sore throat and low-grade fever. Rapid strep test reviewed and negative. Supportive treatment recommended. Common drivers. Basic testing. Low-risk management. Stable patient condition. 99283 ED visit, moderate complexity. Typical clinical situations. Acute illness requiring evaluation. Moderate symptoms. Prescription drug management. MDM characteristics. Problems. Acute illness with systemic symptoms. Data. Labs/imaging reviewed. Risk. Moderate risk treatment. Example documentation. Patient evaluated for asthma exacerbation with wheezing and shortness of breath. Chest X-ray and labs reviewed. Nebulizer treatment and steroids administered with improvement. Common drivers supporting 99283. Prescription medications. Multiple diagnostics. Moderate symptom severity. Reassessment after treatment. CDI focus. Clarify. Exacerbation status. Hypoxia. Severity of symptoms. Acute versus chronic conditions. 99284 ED visit, moderate high complexity. Typical clinical situations. Significant acute illness. High symptom severity, increased risk of complications. MDM characteristics. Problems. Acute complicated illness/injury. Data. Extensive diagnostics. Risk. Moderate to high risk. Example documentation. Patient presents with chest pain and elevated troponin concerning for acute coronary syndrome. ECG independently interpreted. Cardiology consulted. Patient admitted for further management. What commonly supports 99284? High-risk symptoms. Advanced diagnostics. Specialist consultation. Admission decision. Escalation of care. 99285 ED visit, high complexity. Typical clinical situations. Life-threatening condition. Severe trauma. Organ dysfunction. Significant instability. This is the highest ED/E&M level. Severe illness requiring immediate evaluation. Intensive management. High-risk decision-making. MDM characteristics. Problems. Threat to life or bodily function. Data. Extensive review/interpretation. Risk. High risk of morbidity/mortality. Example documentation. Patient presents with septic shock and acute hypoxic respiratory failure. Broad-spectrum IV antibiotics initiated. Vasopressor support considered. Extensive labs and imaging reviewed due to high risk for rapid deterioration. What strongly supports 99285? 1. Clinical instability. Respiratory failure. Stroke symptoms. Shock/hypotension. Severe trauma. Altered mental status. 2. Management complexity. Multiple interventions. High-risk medications. Admission to ICU. Emergency stabilization. 3. Data complexity. Multiple imaging studies. Independent interpretation. Consultant discussions. Extensive diagnostics. Common ED audit failures, 2026. 1. High-level code without severity. Example: chest pain, without describing, concern for ACS, risk level and diagnostic complexity. 2. No risk documentation. High-level codes require potential for deterioration, urgency of evaluation, significant physician decision-making. 3. Generic documentation. Labs reviewed. Instead use troponin elevated at 1.2 concerning for acute myocardial injury. What counts toward E&M time? Included activities: reviewing records and tests, obtaining history, performing evaluation, counseling patients/family, ordering medications, tests, procedures, communicating with other providers, documenting in the medical record, coordinating care. What does not count with time? Staff time, travel time, separately billable procedures, time spent on another date. Difference between ED code 99284 versus 99285. 99284 includes serious illness, moderate high risk, stable after treatment. 99285 includes threat to life/bodily function, severe instability, high probability of deterioration. CDI opportunities in the ED. Clarify: respiratory failure, sepsis, AKI, encephalopathy, acute coronary syndrome. Severity indicators. Put your knowledge to the test for fun. You can pause the video if you accept the challenge. Ready for a quick challenge? Use the descriptions below to take the quiz and see how well you understand evaluation and management. The next few slides are tables summarizing the criteria for evaluation and management codes.
All together.
Thank you for watching. Make sure to click subscribe, follow, and stay updated with our latest content. For just $50, you can access 2 hours of continuing education by clicking or copying the link below. To earn your certificate, simply complete the evaluation.